Hello, candidates for the Upper Cervical Diplomate program. My name is Dr. Stan Pierce, and I want to personally congratulate you on enrolling and beginning your journey in the Diplomate program. You're going to become some of the most highly trained experts in our field for upper cervical care because you're going to have such a balanced understanding of each technique. You're going to be able to not only help with the legislation that will guard and protect our ability to adjust people's atlases, but hopefully you're also going to become some of the unifying factors of the upper cervical world. I get the opportunity and the privilege to introduce you to EPIC. EPIC is an upper cervical specific procedure that is an acronym that stands for Evolutionary Percussive Instrument Corrections. Our mission statement is we believe in challenging the status quo in healthcare as well as in chiropractic. Forever striving to improve our quality of care, we're always looking for the next conceptual or technological breakthrough that's going to help us achieve better spinal corrections for optimal patient health. So, it's all about the patients. It's always been about the patients. It's what can we do to get the patients the best results possible. I'm excited for you that you guys are exposed to all these different techniques, to the different concepts, the articular, the orthogonal, the research, the imaging. The Diplomate program is an extensive program to try to help you be a well-rounded upper cervical doctor. And EPIC, in particular, embraces not only the traditions of the past and reveres our ancestors, and we hold such gratitude for what these guys and ladies went through just to give us the opportunity to have Atlas care to provide to the public. But out of that respect, out of that reverence, out of the sacrifices they made, we find this internal vigor, this enthusiasm, this passion towards where are we going? What are we doing with this profession? What's the future going to be like? And that's what EPIC focuses on. How can we learn from each other and infuse the right concepts in different upper cervical techniques into a single approach? Why does it have to be articular or orthogonal? Why can't it be both? Why shouldn't it be both? So we go back to the history of where this all came from. Beginning with B.J. Palmer, HIO toggle, above, down, inside, out. In the definition of chiropractic, we were led towards the understanding that a subluxation is a vertebrae out of place with a one above or below, causing interference of the nerves. Sure, there's more details to it, but essentially that's the general premise. And the articular model of care began. Toggle becoming Nietzsche, becoming Blair. These concepts focused on looking at the C1 vertebrae compared to the condyles to identify the side and rotation of subluxation. The Grostic-based model, coming along shortly after that, began looking at it with a measurable component that involved engineering concepts. He looked at how to measure these malpositions using mathematics, not general listings, but trying to get it down to a degree-specific application. The Grostic-based models believed if you could measure the malpositions with specific degrees, then you should be able to measure the improvement of those malpositions with the adjustment, also measured in specific degrees. So looking at it from the ability to quantify and control the outcomes of the adjustment. Interesting idea. But then he also threw in the center of gravity component in this concept of orthogonality. Now, if you remember, orthogonal is defined as a condition of having right angles. So that discussion was a line drawn through the atlas, a line drawn through the center weight of the parietal bones of the skull, and a line drawn coming up through the neck, and these lines being at right angles to one another. Interesting concept, a very stable engineering concept. However, the idea that every single person walking around on this earth, when in good alignment, we would all be orthogonal. That's a little bit of a stretch when you consider genetic uniqueness. We're all different. That difference has to be considered if our goal is to correct the patient into their normal. If our goal was to adjust them into orthogonal, we could accomplish that goal. But what if that wasn't their genetically normal position to be in? We might have an issue there. So the other consideration that came along early on in this debate of articular versus orthogonal was the discussion that in the orthogonal model of analysis, we're looking at a line drawn through the atlas compared to a line through the parietal bones. Well, by subluxation articular definition, is that a subluxation analysis? Well, we're not comparing atlas to the condyles, we're comparing atlas to a line drawn through the parietal bones. This created an interesting debate. You have to be able to draw a line through the skull from which to compare the line through the atlas if you're using a degree-specific analysis. And yet, genetically, if the condyles that the atlas is touching are not 90 degrees to the parietal line, then the atlas never should be, if the atlas is matching the condyles. You're far enough along in the Diplomate program that you should understand these nuances, these little discussions. But the point is, when Blair talks about aberrancies exist, they're right. And when Nietzsche talks about the importance of using instrumentation, trying to objectify the presence of neurological interference, they're right. And when Grostic comes along and says, if we could measure the malpositions degree specifically and apply those math coordinates to refine our line of drive, maybe we could control the reduction of all four misalignments simultaneously with a single thrust and look at post-x-rays to make sure we did it, to make sure we accomplished that goal by measuring those same bone structures on post-x-ray. That's a pretty legitimate discussion. That's a good concept, and we would say he's right. When Dr. Sweat came along through the Grostic-based work and said, not just Dr. Sweat, but several doctors said, let's develop an instrument to try to help us decrease human error, maybe be more degree specific, have a better consistency to our adjusting protocols. Epic would say, that sounds kind of right. So if all of these people are right with their different discussions, well, what if we brought it all together? That's Epic's mindset. See, in the mission statement that I mentioned to you, we believe in challenging the status quo in healthcare as well as in chiropractic. Well, all of us would say, great, we're all challenging the status quo in healthcare. We're not about sickness and disease, we're about health and wellness. And we'd all agree. But then what about challenging the status quo inside chiropractic? What about challenging the status quo inside upper cervical care? Are we allowed? I mean, shouldn't we be? I mean, if we can't question each other and we can't challenge each other respectfully out of what could help the patient more, well, who are we? You know, we're not the egos of the past. We're a new generation moving forward, and that's where the passion and excitement of the future is. It's in that youthfulness, that fresh perspective that reveres what we've learned, but is looking towards what we can learn more of. So where did Epic come from? Grostic came from Toggle, where Dr. Grostic used mathematics to try to refine his line of drive. When Dr. Grostic passed away, then began the Society of Orthospinology, where chiropractors began developing instruments to do the adjustment, hoping to minimize human error and maximize accuracy of the adjustment. From this group, Dr. Roy Sweat developed Atlas Orthogonal and began his work with percussion sound wave adjusting. In 2001, my father and I began Advanced Orthogonal, mostly because of the consideration of a patient's genetic anomalies and how that would factor in to a Grostic-based analysis. And in 2014, the board and I, running Advanced Orthogonal, decided to rebrand into Epic. Why? Mostly because orthogonal was not our goal. We now were looking at how to put a patient into their genetically normal position, and from there became a whole movement of advancements and improvements designed to enhance our quality of care for each patient. The Epic exam protocol is a 5-step protocol. The first step is a supine leg length assessment done with a supported wedged pillow and a specific 10-step component to the leg length assessment. The second part of the Epic exam protocol is palpation of the lumbar spinal erector muscles, observing unilateral hypertonicity and correlating that with the leg length assessment. The third component of the exam protocol is a modified deltoid brake test. It's not an AK test, but it has a similar observation to it of pushing against resistance and seeing the body's ability to adapt. We combine that with cervical rotation to indicate to the patient upper cervical misalignment affecting the arm strength. The fourth step is palpation of the C2 dorsal root ganglia, second largest ganglia in the body, second to sciatic nerve ganglia. And if the atlas is misaligned, one or both of the ganglia will inflame. And you can train your fingers with tactile sensitivity to be able to identify this inflammation. The fifth and final step is the Fukuda's standing marching test. We do this for 30 to 60 seconds and observe patient irregularities in their ability to hold center of gravity. This is the 5-step exam protocol for EPIC. Post-adjustment and regular office visits include a minimum of the supine leg length deficiency assessment, the palpation of the C2 dorsal root ganglia inflammation, and likely correlating the low back muscle imbalances till the patient has an identification, understanding their atlas malposition, twists their entire spine and causing the leg length deficiency. The Fukuda marching test and the modified deltoid brake test can be used in follow-up re-examinations to help identify patient progress in your re-evals. Following the examination, if it's determined the patient is subluxated, we then proceed to the 4 X-ray view. It's like the traditional Grostic X-rays, where we take a lateral cervical, which we call a sagittal film. We take a nasium X-ray, which we call the frontal. We take a vertex film, which we call the horizontal. And these 3 films were renamed from Dr. Roy Sweat in Atlas Orthogonal, attempting to name them according to the plane of the body that the film is viewing. But we also have a 4th X-ray called the axial X-ray. Most people perceive this to be an open mouth film. However, we customize the tube tilt for this film to be 90 degrees to the George's line of C2, and the central ray is aimed coming up right at the base of the dens. This gives us the best plane perspective going across the C2 surface, because we're going to be measuring the circles or the contour of the superior surface of C2 as part of our calculations for the leverage in our line of drive. In our X-ray analysis of these films, part of the X-ray analysis is based upon the traditional Grostic orthogonal analysis. So we draw the line through the center of the skull, bisecting the weight through the parietal bones. We also draw a line through the atlas to reference the plane of the atlas, and we draw a line coming up through the cervical spine. Drawn very similar to how the Grostic analysis that you've already probably been exposed in the Diplomate to. However, we do customize these lines a bit further. We observe dents in the skull, parietal tilts, aberrancies of the condyles, aberrancies of the C1 with arch and mass and transverses and all kinds of things. And we also measure the C2 surface for aberrancies, dens aberrancies, C-spine aberrancies, and on the horizontal film we measure for all kinds of aberrancies there too. In total, we measure for 23 genetic anomalies, and how those anomalies would affect our understanding of the correct line of drive, as well as the biomechanics of the table placement that we'll be discussing in a moment, as well as what we would expect the amount of reduction to be from the adjustment if we're adjusting a person and putting them into their genetically normal position. Orthogonal is not our goal in EPIC. Our goal is to put a patient into their genetically normal position. So this is where we really love the Diplomate program, for example, because we're able to look at concepts from other techniques and embrace those into the orthogonal model, such as the aberrancy of the condyles. So for example, if the plane of the condyles is not 90 degrees to the line that was drawn through the parietal bones, then when in good alignment, a patient's atlas should not be 90 degrees to the line drawn through the parietal bones, because the atlas has to match the condyles. The articular concept is legit. So calculating how much of a non-orthogonal atlas to skull relationship is occurring, and knowing how much of that non-orthogonality is genetic abnormality versus misalignment, this is all part of EPIC. Very key to understanding how to adjust somebody and what to leave alone. We always discuss knowing when and when not to adjust somebody. Well, sometimes you need to be able to look at calculations on an X-ray and know what non-orthogonal is normal for the patient and what part of non-orthogonal is misalignment that needs to be adjusted. We take a lot of emphasis on this in EPIC. And that's just one example of one genetic anomaly. Once again, we take 23 anomalies into account, and this helps us customize our treatment protocol and adjusting protocol to match the patient's genetics as well as misalignment. When we take these coordinates off of the x-rays, it's not just studying the x-rays to obtain the line of drive for our instrument. It's also understanding the biomechanics of the malposition. Because there's a concept in upper cervical, especially in some of the NUCA or Grostic hand adjusting procedures, where you'll hear people talk about breaking the resistance inside the joints, the resistance inside the subluxation. Well, one of the difficulties, or challenges, I should say, of using an instrument rather than a hand adjustment is an instrument delivers a static mechanical impulse. You don't vary or fluctuate the direction or the lead for this. It's an exact line of drive aimed at an exact part of the atlas. So the breaking of the resistance inside the friction of the joints is something that we have to accomplish with a different protocol, a different approach. And how do we accomplish that is in our table placement, with how we place the patient on the table for the adjustment. I jokingly talk to the students about this is just setting the mood to allow for the adjustment to work right. And how you set the mood is you make sure that everything is encouraged and influenced to reduce when that impulse hits the structure. So we have 7 steps to our table placement protocol. One of those steps, for example, is placing the skull up onto the headpiece correctly. We have 6 different parts to that one step. Being able to align the skull and the atlas underneath it to the center point of the headpiece without any variables that would affect the accuracy of the impulse is critically important. And this 6-point head positioning is exclusive to EPIC. Besides that, we'll influence the shoulder positioning, superior for an ipsilateral pattern, or we'll take the distal shoulder inferior in a contralateral pattern. Different ratios, different amounts based upon the misalignments seen on the x-ray. If the C2 spinous is misaligned one direction, we'll rotate the shoulders opposite of that, and we'll do that proportionately for the amount of C2 misalignment. We'll also acknowledge the posterior and anterior atlas and how we can encourage that joint complex to release that rotational misalignment with our impulse by changing our headpiece angle. And that headpiece angle is also customized based upon genetics as well. So every component of this, it's important that we are fully aware of what genetic uniquenesses a patient has. So for example, if a patient's C2 body is higher genetically on one side than the other, well, the atlas would not sit orthogonal to the cervical spine. And that could create a lower angle or an acute angle between the atlas and the C-spine, some of which is just genetics. So how does that affect our ratio of how hard we influence things to decrease friction in the joints? Well, it matters. So when we break the resistance, we can only really reduce the friction in the joints by understanding what the genetics first dictate, understanding secondly what the subluxation calculations dictate, and combining both of those pieces of information allows us to customize our table placement joint influences most ideal. The next component would be calibrating the adjusting instrument. Calibration means you're taking coordinates from the x-rays that say, hey, here is the necessary line of drive, and we're now going to take the calculations and import them or plug them into the instrument. The problem is that the instrument is going to zero out according to itself, meaning if the instrument stylus was straight up and down at a 0-degree setting, well, that would be 90 degrees to the table surface or the horizon of the earth. But when a patient lies down on their side, due to the inconsistency of the width of their shoulders compared to their waistline, they're going to lay elevated from that parallel tabletop. So however many degrees of elevation that person is angling is going to be additional S to I leverage even from a 0 degree set instrument. So if the instrument's at 0 degrees straight up and down, but the patient's side-lying position puts their neck at 9 degrees above parallel or level, that's going to be a 9 degree S to I adjustment. That's error that must be calculated if you're going to calibrate the instrument to adjust the patient, not the surface of the table. So we do take that calculation. That was back in 2004 when I figured out that missing calculation, which we called the head height angle, and that is incorporated as the plane of reference by which we then apply our S to I component of our adjusting line of drive. Additionally, we have to center the skull to the headpiece. Positioning the skull on the center of the headpiece is critically important to the accuracy of our adjustment. Epic was the first to design, incorporate, and include into our adjusting protocol a laser-guided assistance to locating the skull into the center of the headpiece, which is currently in the patent process. By accurately calibrating the instrument to match the patient's body position, we can decrease error in the calibrating system. And when we decrease that error, it actually increases the tolerance range by which our adjustment can be more effective because we've removed those mathematical errors. Lastly, we're going to take the stylus and we're going to aim it directly at the TP location. So we find the transverse process by looking at the x-rays, comparing multiple viewpoints, and identifying exactly where the transverse process is compared to the mastoid and mandible. It's a very interesting discussion, especially for the Diplomate program, because there's this whole discussion about using an instrument and whether or not that can move a bone with sound wave or with excursion. And there's been some interesting questions that have come up that I thought would actually be fun to handle inside the Diplomate. If we were doing a live session and I opened this up for Q&A, some of you guys would ask me some of these questions because we get asked this all the time. Well, if your instrument, I've heard that you guys don't have your instrument touching the skin. No, we don't. We're barely off the skin. And some people have said, well, then how could that move the bone? And I say, well, my sound wave is not, it's not like my lips are touching your eardrum right now. I'm sending sound wave through the air, then through the soft tissue eardrum, vibrating your hard tissue inner bone parts, and the nerves connected to them. And that's how you've learned communication. So it's sound wave going through air, then through soft tissue, then affecting hard tissue, and now you're hearing me. So sound wave can do this. It's not a discussion of whether it can do it or not. The next part of the interesting discussion here for me is that I say, you know what? None of us are actually pushing the bone. Think about it. There's at least 3/4 of an inch to an inch worth of soft tissue between the surface of the skin and the bony aspects of atlas. So every one of us is sending our force, whether it's manual, whether it's an excursion instrument, whether it's a sound frequency, we're all sending our force through soft tissue, affecting hard tissue. We're all doing it. So it's not a matter of somebody saying, well, I'm pushing the bone. You're sending force through soft tissue to affect the bone. So are we. The reason why we're slightly off the skin, in case you wanted to know, was the sound reverberation. It'll actually spread across the surface area when it's in contact with the skin, like muffling the sound a bit, rather than being slightly off the skin to leave it for more pure delivery. Ultimately, what you have to ask is, do they, meaning Epic, do we have evidence that this acoustic wave is actually moving the bone? Well, yeah, that's where you come back to your neurologic changes and your structural changes on post-X-ray. If it's there, guess what? That means we're moving it. So ultimately, it just comes down to, well, what are the facts saying, rather than what's my opinion. Same thing I allot to each one of you with your techniques as to who am I to say whether your techniques are doing what you claim they're doing or not. Let's just look at the data. Show me the pre-post findings, and now we know what's going on. That's what Epic's doing as well. So the step of aligning the instrument's stylus to the transverse process of the atlas. This is an important step. Sometimes there are anatomical complications to being able to adjust an atlas. I know you guys have seen these. Sometimes you'll have the ear cartilage that gets in the way, because it's somebody who their ear just developed too low, or they have a low earlobe, or they have platybasia, and the bottom of the skull softened, and so the atlas is recessed along with the condyles up underneath the skull. These are all cases where you could have some serious complications to being able to contact the atlas. Additionally, you can sometimes have the mastoid that gets in the way of being able to contact the atlas. Well, we have a single directive in EPIC. We have x-rays that have given us calculations, and we have to calibrate those calculations in a specific line of drive to hit the atlas TP. We can't aim somewhere else, or we're not hitting the atlas TP. We can't change our calculations, or we have left our science. So in EPIC, we will always use our calculations from the x-ray, calibrate them into the instrument to match the patient's body position, and then aim the stylus at the transverse process regardless of what else is in the way. So sometimes you'll hear people say, well, you can't send a sound wave through the mastoid. And I'll say, of course you can. Have you seen our x-rays? Did you see the testimonials? Did you see the nerve changes? Some people say, well, you put the instrument way up here inside the ear. Be like, yeah, they had a very high line of drive with an atlas transverse process that had developed really far up inside that fossa. So yeah, we had to go up there because remember, our force has to conclude at hitting the atlas 3/4 of an inch to an inch deep. So we have a lead to our instrument so that our resultant adjustment will hit that point 3/4 of an inch to an inch deep. The great thing about using an instrument is, well, it's not my big piezoform, so I can put it into tight locations and still maintain my accuracy. That's a benefit. Another aspect to EPIC, which is a complete innovation, I mean a major breakthrough, is we now have a 3-axis calibrating adjusting instrument. So if you guys think closely on your biomechanics, remember your old Z, X, Y? If you think about it, think closely as to which axes the atlas is misaligning around. So the laterality of atlas goes around the condyles, which means it's moving around the Z-axis. Therefore, if it's moved around the Z-axis, a line of drive to match that would be considered a Z coordinate setting for the instrument. Well, next, the atlas misaligns rotationally around the y-axis, which is an axis shooting straight up. Most of the instruments pivot around an axis shooting straight vertical, calling it a y-axis. But think closely. When that patient lays down on their side, their y-axis is no longer shooting up. Their y-axis is now shooting up the table. Which means most adjusting instruments are designed to adjust around a Z and X axes, calling them a Z and a Y. Major mathematical considerations on this. Because you're attempting to use a Z times X equals Y instrument to correct a Z and Y misaligned atlas. Don't forget the head height angle of a patient in the side-lying position, modifying the Z instrument setting to match the patient's body posture. Well, now you've modified the Z times X equals Y by changing the instrument's Z. Don't forget the patient may not be laying in the center of the headpiece, so that could change your X altogether. Major complications. If we're trying to be accurate and we're trying to be pure in our delivery of the adjustment, it would make sense we would have an instrument that could pivot on both the Z and the Y independent from each other. Pure calibration. And that's what EPIC has. We also have a laser-guided assistance in aligning our stylus to the transverse process. We actually have part of our instrument that will shoot a laser and show you 1 inch off the tip of the stylus where the adjusting force will go. And our doctors train to learn how to use that to make certain their adjusting force is going to hit the atlas TP 1 inch deep. So we're trying to get more specific. That's what upper cervical has always been about anyway, being specific. Upper cervical is supposed to be constantly getting more specific. Less and less error, higher accuracy. That's what we're going for. Of course, the proof is in the pudding. You have to take your post x-rays, measure the structure using the same references of anatomy on the posts that you did on the pre, and see what the numbers show you. If the numbers showed that you controlled all 4 misalignments with a balanced reduction, putting a patient into their genetically normal position with a single impulse, well done. You did a great job. If the x-rays show you were banging things around and didn't control anything, well, you might want to reconsider your application of your adjusting technique at that point. So what do we do with this information then? Of course, the post x-rays are not just to show off. They're not just to brag on how well we fix somebody. It's actually for us to make certain that our adjustment did what we claim it does. It's kind of interesting, too, that if you think about a court of law or an ability for a scientific community to look at your pre-adjustment criteria and see if you're using it for post-adjustment outcomes, it creates a consistency that's kind of objective because the mathematics can guide you and tell you how things went versus me standing on the stand as a witness and say, well, no, I adjusted them, I did it gently, and I fixed it well. That's like opinion, right? So if mathematics can objectify my opinion and can actually validate it, excellent. I'm in a much stronger scientific position as well as legal position. Additionally, though, being able to track your pre and post x-ray outcomes and know how you're doing is critically important for your quality control. And this is one of the things Epic emphasizes really strongly. We must be in control of our quality of care. This is not a matter of us just throwing bones around and good luck, innate. This is not a matter of us just saying, well, our intentions were there. We tried to be gentle, Chiropractic works. Yeah, chiropractic does work when it's done right. And the philosophy of chiropractic is strong and true. And innate is responsible for all the healing. But for us to claim that innate's responsibility is to do the alignment, is to put the bone where it decides it wants to. Well, what if a patient has a negative outcome to an adjustment? I mean, was that innate's fault? So this is one of the things in Epic we emphasize is our technical excellence is critically important. Critically important. So if we're really committed to quality of care, well, now I get to introduce you to the future of Epic. We have a software tracking program called Sonus Blueprint. This software tracks every patient walking into Epic clinics around the country, around the world. Each patient's demographics is tracked, chief complaint, exam findings, general x-ray findings, and specific biomechanical misalignment findings. It also tracks the post-x-ray biomechanical findings. Why are we doing this? Because we can statistically see exactly how well Epic Care corrects patients. We can measure it on an international platform, doctor to doctor, multiple locations, international as well. And we can establish a status quo, a standard of care by which we can all be held accountable. Think about the beauty of this. Not only does this give us a massive data mining program by which we will just pummel the research journals, but what it does in-house for our quality control, it allows Epic to observe its doctors and how they're doing in every single detail of every case. So we can see which doctors might be struggling in a certain case type with a certain piece of those case types. And we can send them a webinar, invite them to a seminar and say, hey, we need to reach out to you. Your ability to control that component is slightly below the Epic status quo, and we want to help you. We want to help you get up to the quality that our Epic community is producing. But you know what else it does? The most exciting part of what it does? We can see if a doctor in their practice with a certain case type is killing it. I mean, they're way above us. What if we were to see a doctor is just statistically reducing certain types of subluxations or certain parts of certain types of subluxations better than the rest of us? We can see the breakthrough that happened in that doctor's clinic before the doctor would even know he had a breakthrough. Think about that. In all of our techniques, there are doctors that excel. There's doctors that do better than the others. But who really knows? Well, maybe they get a good reputation, or maybe you say, well, that's the only doctor who can clear me out with our procedure. Wait a minute. Why wouldn't each doctor be being held accountable for a quality of care? And if we're all at a certain quality and we can statistically see that breakthrough, we can learn from that doctor. We can contact him and say, hey, you've had a breakthrough. You're controlling this component of these case types better than the rest of us. What are you doing? We need to FaceTime with you. We need to have you show us what it is that you're doing to apply your leverage, your resistance, breaking the resistance, or you're doing something different. You've had a breakthrough. We need to learn from you so we can keep elevating the standard of care in Epic. Elevating it, elevating it. That is so exciting. In most techniques, you have individual doctors in their clinics. Some of them have a breakthrough, but because there's nothing to compare it to, they don't even know. So they can't pass that advancement on to the rest of the doctors in their technique. In Epic, we can. We see it, we reach out, we learn from it, we grow together. We're raising the bar, developing Epic's standard of care that will continue to raise higher and higher and higher with these statistically demonstrable breakthroughs. So we're excited. We're incredibly excited. We're looking forward to seeing how this kind of data can start helping to put upper cervical on the map, can help start to get the scientific community respecting us more. But think about this. If we're measuring not only how well we're reducing subluxations, but also the holding patterns connected with accurately reducing certain patterns, well, now we can have a discussion about gauging patients' care plans, where most of the time a new patient comes into us, and what do we all say? Well, here's how severe your condition is, so here's the number of visits I expect you're going to need over this given period of time. And the patient can say, well, how do you know I need that? And most of us will say, well, in my experience, this is what you need. When in reality, it might be, this is what my practice management consultant told me to schedule all my patients at, something like that. So what if instead a patient says, well, how do you know I need this number of visits? What if you're able to say, because every patient that walks into an Epic clinic just like mine has their statistics tracked. 8.3% of those people who walk into clinics just like mine have your exact misalignment pattern. Typically, their first adjustment causes a 60% reduction of all misalignments, and they typically will require 3 adjustments over a 4-month period of time with a checkup frequency this often. That's why we're going to schedule you as your baseline to start with. Might need to see you a little more frequently if you're messing it up, or maybe see you a little less frequently if you're holding better than the average patient. However, that's what the statistics show your case will respond to, so that's how we're going to establish your care plan. I mean, boom, mic drop, right? I mean, there's no arguing here. This is not an opinion discussion anymore. The math is guiding us. Do you know how excited we are about this? So that's where Epic is going. We are looking to create a community where quality control matters. The phrase we use is we're creating Epic spinal engineers. Yes, we're chiropractors. We love the profession. We're not leaving it. We're not changing our name. No, we love chiropractic. And we are working to bring ourselves to the highest level possible to help us get our patients corrected as good as we can. With the technology that we have now and the concepts we know now, but 10 years from now, if I'm getting the same quality results I am today, shame on me. I mean, I should be getting way better. We all should be getting better. One of the phrases we do use in Epic is called compared to what? We all say we're doing good work, and I say, okay, compared to what? Well, that was a good adjustment. Compared to what? And that patient responded well. Compared to what? Compared to another patient? Your adjustment was good compared to your last adjustment, or compared to that NUCA adjustment, or that Blair adjustment was good compared to my Epic adjustment? Or we have to compare it to something, or we're all just walking around talking about how great we are, which is very unifying. I get it. It's very emotionally uplifting when we're all talking about how great chiropractic is, and especially how great upper cervical is. And I am a massive fan of each one of you. and what it is you're trying to do for your patients. Massive fan. However, we should all still challenge. We should continue to challenge ourselves to get better. We should find ways to measure our quality of care and bring that quality up. We should learn more from each other. There should be more technology breakthroughs, not just in diagnostic imaging, but in how we're correcting patients, what devices we're using to adjust them. And I understand the whole chiropractic versus instrumental-practic debate. I get it. But the whole point is, how well are we going to fix somebody? How well can we correct subluxations? I mean, that's my bigger concern. Rather than, did I hold an activator? Did I use a drop table? Did Toggle have a drop headpiece? There's so many things that are not by hand only. So it's not really a debate like that for me. And I hope it's not a debate like that for you. However, just consider, what are we in this for? It's always about the patients, right? So whatever we can do to get the patients the best results possible, clear their nervous system the best, get them holding the longest, so they can have that innate recovery that they deserve, that they were meant to have. Then we can all rejoice about the testimonies. The testimonies are second to our quality of care. Our quality of care is our most precious thing that we have to offer patients. So I hope that this brief explanation video of Epic to introduce you to some of the basic concepts, I hope that at least that might have inspired you that here we are running alongside of you, working to improve our quality of care like I hope you are too. I'm proud of you for going through the Diplomate. I wish you well. It's a hard course. It was designed to be. Thank you, Bo Rochester and Julie, for developing the curriculum as tough as you have. Great criteria. Thank you to the ICA Council, the board members that I was with originally, for pushing this agenda and making this happen. This is a worthwhile program, and you guys are to absolutely be complimented and respected for going through it. Look forward to seeing you soon.